you may see 100 people with nausea and vomiting from these meds, but you may only see one or two that have it because they have pancreatitis or
Mhm.
have it because they're actually pregnant. So you really have to have due diligence in making sure it's not just the nausea and vomiting from the medication.
Welcome to the Evidence-Based Urgentology podcast from EB Medicine, where urgent care meets evidence. I'm Joe Toscano, Senior Research Editor for Emergency Medicine Practice and a member of the Evidence-Based Urgent Care Editorial Board.
Hi there, and I'm Tracy Davidoff. I'm Editor-in-Chief of Evidence-Based Urgent Care, and we're practicing urgent care physicians with years of experience, probably too many years of experience, on the front lines. And for us, diagnosis is detective work, and the clues are in the history, the exam, and of course, the evidence. That thrill of solving the patient's puzzle is really what keeps us coming back.
Each month, we unpack the latest issue of Evidence-Based Urgent Care, tackling common chief complaints from presentation through diagnosis to disposition. We highlight the best evidence, the key takeaways, and the clinical pearls.
And by the end of every episode, you'll have sharper skills, deeper knowledge, and more sound strategies that you can use on your very next shift. So let's dive in. The evidence starts now. And remember, you can always find more at www.ebmedicine.net.
Hi, everyone. We are here to record the podcast for the April 2026 issue of Evidence-Based Urgent Care on weight loss drugs in urgent care and managing complications and that sort of thing. I'm going to start off with some promos. There is a podcast exclusive promotion. Use the promo code podcast, that's PODCAST, to receive 10% off your subscription and Points and Pearls, the year in review for both 2024 and 2025. That is a $794 value that highlights key clinical insights from the past 2 years of evidence-based urgent care and our podcasts. And there's one more promo. EB Medicine has rolled back their pricing to reduce barriers and make trusted evidence-based education easier for clinicians to access. To see their new pricing, visit www.ebmedicine.net/subscribe. So the authors of today's article are Hannah Kaplan, who is a resident at University of Kansas Medical Center in Kansas City, Kansas. Dr. Tyler Johnson, who is Medical Education Fellow in Emergency Medicine at University of Kansas Medical Center in Kansas City, Kansas. Dr. Hope Ring, who is Associate Professor, as well as Medical Director of the Legacy Urgent Care at University of Kansas Medical Center. And finally, Dr. Michelle Wilson, who is an Assistant Professor of Emergency Medicine at University of Kansas Medical Center.
Awesome.
Yeah.
They were unavailable to chat this time around. So instead of having the authors, we decided, hey, let's get one of the peer reviewers to chat with us. So we have Erin Liu. Why don't you tell us about yourself?
Hello, Joe, and hello, Tracy. I'm a physician assistant, and I practice in College Station, Texas, with a group called Express, and my urgent care is called Integrity Urgent Care. I've been in urgent care since 2007, and I also serve on the board for the College of Urgent Care Medicine. I'm the secretary right now, and that's been quite a lot of fun.
And actually, the reason why we asked Erin to be the peer reviewer in this article is because she actually did an article for us in Urgent Caring, the publication for the College of Urgent Care Medicine, about weight loss meds. So I thought she had already done some research, so she would be the perfect person to peer review. And then when we couldn't get the authors, we thought, hey, let's have her join us on this podcast. So this is really an interesting article. And the reason that I was looking forward to having somebody write it for us is because this is really a hot topic in all of medicine right now. The weight loss meds. I feel like the GLP-1s have really changed how modern medicine thinks about weight loss and really a lot of how people are losing weight, because it's now more of a medical problem than, well, you just didn't diet well enough. We now understand a lot more about the endocrine aspects of this. But, the bad news is that everybody's clamoring for these medications. And because of the expense and the difference in access to care, people are getting these meds in different ways than normal mainstream medicine. So because of that reason, it's really important to ask people about these medications. I find, and I'm sure you guys find too, that people don't really consider something that's not a pill or something that they don't buy from the pharmacy, a medication that they might be taking. I have people that forget to tell me about insulin because, hey, it's not a medication, right? I'm injecting it. It's not a pill that I take. Or they forget to tell me about their inhalers. So it's really important to ask people about these medications. If they get it online or if they're getting it from, God forbid, Mexico or something like that, they may not think to offer it up to you, either because they just forget or because they might be embarrassed that they're getting the meds elsewhere, or because they don't really think that, hey, my doctor's not prescribing it or it's not in the EMR, so I don't really have to tell you about it. So,
Mhm.
always think about this. And like I said, many people are on these medications and losing weight. There are a lot of side effects associated with these medications. So, as urgent care clinicians, we really need to be aware of the side effects of these things, mostly GI, but also constipation, nausea, vomiting. And these things start with initiation. But if you get used to the dose, the side effects tend to resolve. So, the side effects will also increase when you increase the dose. If you're not familiar with how these things are dosed, you go up in a stepwise fashion until you get the desired effect, usually maxing out at a top dose. And most of these side effects and symptoms that people get with these drugs can be treated in urgent care.
Mhm.
Erin, I wanted to ask you, in your practice, I know you see a lot of college kids, and I'm assuming there's probably a lot of them that are taking these medications. Do you see a lot of side effects of these meds in your clinic? And what are the average things that you treat in urgent care?
Yeah. So just to go back to your point too about asking that they're on these medications, I find that is one of the keys to treating these patients because, like you mentioned, patients aren't always talking about the fact that they're on these medicines and where they came from. So when I'm talking to a patient that might be having some side effects, I don't say, "Are you using a weight loss medication?" I like to try and go around the issue and ask in a few different ways. So always asking, "Are you injecting something like you mentioned? Are you using medications you got online?" One that's big for me in my college town would be, are you taking any of your friends' medications? We've had that happen quite frequently too. I like to say, did someone prescribe this for you? Because our college students are getting these medications online and they're not even talking to someone before it gets prescribed to them, which I think complicates things quite a bit because they're not getting the patient education. They're not being told, hey, you need to monitor how much you're drinking, taking in smaller meals, how to manage their constipation. They're maybe not getting medications to take if they're having a complication. My friends that prescribe these weight loss medications. They do lots of patient education. They're sending everybody out with some ondansetron to take if they're having nausea and vomiting when they're advancing on the dose. And if you're getting it online, you may not be getting any of those things. Also, I think it's really important knowing if they're getting it from a pharmacy, if they're getting it directly from the manufacturer, is the medicine compounded? Because that can be leading to a lot of these side effects too. They're not getting a consistent dose. A patient will tell me, well, I've been on this medicine for 4 months. Well, this vial is a completely different dose than the one that you
Mhm.
had last month. And so I think that finding out where they're getting these medications from can help you really understand a little bit more of the kinds of complications that they're having. And sometimes, even when they're compounded, they might be compounded with an inactive ingredient. So maybe there's vitamins mixed in with it that is actually what the patient is reacting to. And so I really like to try and take a really good history if I think that one of these medications may be what is causing their side effects. To your point about side effects, I do think that the main one that we see obviously is nausea and vomiting. That's just the easiest one. Again, I work in a college town, so they increase their dose and now they're missing class. It may not be something dramatic, but it is something that kept them from going to school. But we have seen some really significant nausea and vomiting with these medications. Reflux is another big thing that I see people having heartburn and chest pain and things like that from them. I've seen a patient with urticaria, but I think that was more of a reacting to the vitamin that the medication had been mixed with. And that was something that was happening to her every week that she was taking the medication. And then abdominal pain of all sorts, whether it's just because it slowed down their gut motility and they're just having food sitting in their stomach a lot longer and that doesn't feel good. Or do we have to be concerned that they're having a more significant complication like gallbladder problems, pancreatitis? We did have a patient come back and let us know that his abdominal pain turned out to be gastroparesis and he had to stop the medication and had been working with a GI doctor about that. So it can be something really subtle all the way to something pretty dramatic. But I think also another takeaway is to don't assume that just because a patient has a BMI under 25 that they aren't on these
Mhm.
medications.
Yeah.
There's just a big spectrum of patients using these medicines and a big spectrum of side effects that we're seeing with them. So, Joe, how are you working up a patient that you see with nausea and vomiting?
Yeah. So nausea vomiting is just such a non-specific symptom. Think about it as being a GI symptom, but it could be related to neuro stuff, metabolic issues, even GU problems, pregnancy. So starting off with good history, just like you said, and then peeling back the layers of the onion, I'd say I've probably seen a dozen or so patients with complications, particularly of GLP-1s, which seems to be the most common. And about half the time they'll come in and they've had enough education about it that they'll say, hey, I'm taking a GLP-1 and I can't stop throwing up. But about half the time, you really have to look somewhere else to get the medication. The sickest patient I ever had was in the ED, and she had gotten medication from Canada and started off with one of the middle doses, like 1 milligram or 1.7 of the Wegovy, and just started throwing up so badly. At some point, passed out on her kitchen floor, and her daughter went to check on her a couple days later, and her BMI was 23 to begin with.
Jeez.
And
Yeah.
she ended up having a creatinine of 6. Luckily, she threw up enough that she wasn't hyperkalemic, and she got better with IV fluids, but she didn't tell me she was taking it. Her daughter came in, and her daughter mentioned it. She goes, "She got this medicine from Canada." And this was probably 2 or 3 years ago, right when it first came out and you heard about people getting it out of the US. But I think history is super important, and then going through the review of systems to broaden just beyond the usual things that we think about, and doing a very good exam. I think you got to palpate the abdomen, and any significant pain or significant tenderness, you're going to start to think more about not just a side effect, but more like that this is causing pancreatitis or biliary tract disease that is known to be also a side effect of the medicine, or a true kind of adverse reaction or a complication of weight loss. I mean, the gallstones are probably more related to that than a direct effect of the medicine. I think labs are somewhat important too. I think any woman who's childbearing potential, you want to do a urine pregnancy test. If there's any urinary symptoms, go ahead and do that. And then some people are on these medicines for diabetes. So finger stick blood glucose is important. This is something that we can do in urgent care. Is it super low because they haven't been eating at all? The medicines do cause hypoglycemia, or are they taking it for diabetes and now they have euglycemic decay, or they truly have decay and the nausea vomitings from that, maybe because they haven't taken it for a couple of weeks. So I think the history has to be the starting point, and then you can go from there, put it together with your exam, and decide if you can take care of it at urgent care or whether you need to refer on.
Yeah, I think one of the important points there too is don't automatically knee jerk assume that, oh, this nausea and vomiting is just because they're taking these medications.
Correct.
I mean, you may see 100 people with nausea and vomiting from these meds, but you may only see 1 or 2 that have it because they have pancreatitis or
Hmm.
have it because they're actually pregnant. So you really have to have due diligence in making sure it's not just the nausea and vomiting from the medication. To Erin's point about education, absolutely. A lot of these people don't even know how these meds work. And you're like, well, I feel so bloated and oh, I feel so nauseous all the time. Well, that's what you're supposed to feel. That's how you lose weight, right? Because it delays the gastric emptying. And until you get used to that sensation and
Hmm.
realize that this is what's deterring me from eating, this is how this is actually working. I actually have one lady that said to me, really? I had no idea. And I'm like, do you not ask questions about these things before you start taking these medications? Or I had one lady that was gorging herself on food. Like, are you dieting? And she's like, no, I'm not dieting. My friend told me that you just drop the weight magically. And I'm like, well, you have to decrease how much you eat. You're just going to feel miserable all the time. I guess you figure it out sooner or later. When every time you eat, you feel miserable. Maybe I'll just eat less. But, a lot of people don't really understand these things. We can't assume that every prescriber is going to explain it to people. And to your point, people getting it from other people. Just a word about microdosing that we didn't really mention is that this is kind of a trend now, and people are splitting up their meds and taking less so they can either share it or make it last longer because it's so expensive. So definitely something to think about too, is to ask about that. Are you taking it the way it's designed to be taken? So I just wanted to kind of mention about how to treat that nausea and vomiting. You've rolled all those things out. You don't think it's pancreatitis. You don't think it's gallbladder. You think it's definitely a side effect of the medication. First, you want to make sure the patient's hydrated enough to deal with it. Can we just do a PO challenge, or should we be giving them some IV fluids? So to Joe's point about the urinalysis, great idea. One, you want to make sure she's not pregnant and doesn't have a UTI, but maybe look at that specific gravity and see if they're a little bit on the dry side. Are their
Hmm.
vitals stable? Are they dizzy when they stand up? Do they need some hydration? And if you can do it orally, that's great. Maybe you give them some antiemetics and try to do some electrolyte solution. I'm a big proponent of the WHO oral rehydration solution. I went to medical school in the Caribbean, so this was a regular occurrence for us. There was no Gatorade in Grenada. So we used to make our own with a little salt, a little sugar, and a little coconut water. If you can't do that, then you're going to have to give them some IV fluids. But nothing says you can't give them some meds and try first to see if you can get the nausea and vomiting to stop with some medication. And the important point here in the article is to try to avoid the metoclopramide. Ondansetron is fine. That's great. I always love the ODT form. I can never understand why you would give a pill to somebody who's vomiting. If you're vomiting and you're going to take a pill, aren't you going to just vomit the pill? So either give something parenterally, or in the case of the ondansetron, you can give it ODT so that it'll melt on the person's tongue, and then you give it a little bit and see if they can take some PO. And the reason we want to avoid the metoclopramide is more theoretical than proven. But if you remember, the way metoclopramide works is it increases gastric emptying so that you're emptying the stomach of whatever it is that's making you nauseous and making you want to throw up. Well, as we just mentioned, that is the point of these GLP-1s, is to delay that gastric emptying so that you feel full. So it would be counterproductive to give the metoclopramide. Obviously, if that's a goal to try and counteract the side effects of that, and you're going to be discontinuing the medication, that might be something you might want to do. But if you're going to be continuing that medication, then metoclopramide is a counterproductive idea. So we want to try to avoid that. So if you've decided the patient doesn't need IV hydration, or you're capable of doing IV hydration and you can get them to a place where you can send them home, that's great. But if you're not able to hydrate them adequately, or you think that their hydration status is a little refractory to the treatment that you can provide in urgent care, then it's time to send them forward to the emergency department. Erin, can you maybe review a few of the other indications about why you would want to send somebody to the ED when they present with a complaint related to a GLP-1?
Yeah, to your point about the nausea and vomiting, most of the time we are able to get patients under control, comfortable, and able to send them out. I will say that sometimes these patients can become pretty complicated. Joe was mentioning his patient in the ER. I had a patient who took her roommate's full dose of the medication. It was sitting in her microinjector on the counter, and she'd never taken the medicine before. She said, my doctor was going to prescribe this medicine for me. So why would he prescribe something that would make me so sick? Then we had to go back and say, because you should have started with a quarter of this medication and worked up over several months. Now here we are. And she was the sickest patient that I've had. We started an IV in her. We gave her so many antiemetics, and we could not get any of it to break in any way. It was dramatic vomiting. Everyone in the building knew that this girl was there sick. And so
Wow.
these things that happen with these medications can be pretty significant. And so obviously for her, we started to get concerned about dehydration. Is she going to be able to maintain her electrolyte status? Is she going to get hyperkalemic? All those kinds of things. Do we need to worry about her kidneys? And so just the time we invested in trying to take care of her taught me a lesson that we want to keep these people out of the ER, but there's just times that we can't. And we need to just go ahead and send them so that they can get to a higher level of care. I can't remember what ended up happening with her. She ended up, I think, being even admitted for a short period of time so that they could get her nausea and vomiting under control. Because if you think about it, these medicines have a really long half-life. And so they're in their system for a long time. Even if you get them under control, it can all start back up again. And so those are all reasons to think about sending someone to the ER. But then the other more significant, more rare complications would be that really severe abdominal pain. I think Joe mentioned this, doing a really good physical exam. Are they having right upper quadrant tenderness? Are they having epigastric pain? Do they have any kinds of signs or symptoms you think would be consistent with an obstruction? I hadn't actually known until I read this article that appendicitis was becoming a more commonly reported issue with the fecalith, the slowed gastric motility, and the constipation, leading more people to getting appendicitis. And so that was definitely a new one for me to think about as part of the differential in these patients on GLP-1s having abdominal pain and these more rare complications. We think about the nausea and vomiting, and it can be so dramatic and in your face. But I know another complication would be constipation. So, Tracy, what are you doing for these patients that are having that as their chief complaint?
Yeah, this is tricky. And not only does it decrease stomach motility, but it decreases pretty much all of GI motility. And a lot of these people are mid 20s to mid 50s women who often struggle with constipation at baseline. So if you're already starting out constipated and then you add all these medications and decrease that GI motility, it's a perfect storm for constipation. So there's a lot of tricks. The first one with any constipation, really, not just GLP-1 though, is dietary modification, making sure that you're getting enough fiber, making sure you're getting enough water to try and treat it. Then you can add things like the prune juice and that sort of thing to try and help. If you have to, you can add in some over-the-counter dietary fiber. They make fiber gummies that are really good. Metamucil, other brands of fiber is a good idea. Supplementing magnesium is turning out to be a useful thing. Now, remember, milk of magnesia is magnesium, right? But if you're
Yeah.
supplementing it as a tablet, as well as maybe something that people take every day, that's a good idea. You really want to try to avoid laxatives because this is going to end up being a chronic problem. You're on these meds chronically, maybe even lifetime. We're not quite sure how long people are going to have to be on these meds because they are starting to see that if you do stop them, the weight loss comes back. So there may be some sort of maintenance to do for this. So this may be a chronic problem. And you don't want people to be on chronic laxatives because of either the abuse or just the amount of problems that you may have with taking a laxative long term. So laxatives are your last choice. There was actually an article that I just saw online maybe a day or two ago that was saying that Miralax really is ineffective for constipation related to the GLP-1s. I'm not sure there was any real science behind that, but that might also be a concern. So try to do it with dietary first and then add in the high fiber if you need to as a supplement, maybe some magnesium, and the laxatives only when absolutely necessary.
That's interesting about the PEG because that's
Yeah.
panacea for constipation. If it wouldn't work for
I
that, that'd
know,
be
yeah, we talked about that
tough.
in the constipation article, but yeah, so,
Right. Oh
this
my
is
gosh.
this is ongoing. The
We'll have to
research
see.
involved in this is ongoing, so we're gonna have to see where it goes and take
Yeah.
it from there. Jim, you wanna maybe talk about some of the other drugs? I mean, we're focusing on the GLP-1s. I don't see too much of these other drugs, although the phentermine is popular in Florida, and I see people on it for years and years and not losing any weight and not really understanding why they're on it, but in New York, I never saw it, but go ahead and tell us about it, please.
Well, I think it's interesting that they included some of the other weight loss meds in it. They kind of all fit together. There's no data on prevalence or incidence, but it does seem like the GLP-1s are the things that we see the most. But you don't know what the denominator is. It probably a lot higher denominator for people on these versus the other ones, although I guess we just don't know. Of the other ones mentioned in the article, the one that's been around the longest is Orlistat, which is a medication that actually inhibits pancreatic lipases. So it kind of slows down or prevents the absorption of fat from the gut into the bloodstream. So the fat stays in the gut. And as you can imagine, the stools become oily, get a lot more gas production, and loose bowel movements can result from that. Those are the main side effects of that medication. You had mentioned phentermine, which has been around for a long time. It's a stimulant medicine, basically, not really an amphetamine, but I think it's pretty close to an amphetamine. So you can imagine the side effects of that would be palpitations, insomnia, anxiety. The phentermine alone has been around for a long time, but the medication mentioned in the article is it in combination with topiramate. Topiramate is a mood medicine, but decreased appetite is a side effect. So combining those, now you have a stimulant appetite suppressant and then one that it's actually a side effect of the Topamax. The Topamax has its own set of side effects, although it's probably better tolerated than the phentermine alone. You can get taste alteration and paresthesias with the topiramate component. Now, naltrexone and bupropion, both of those medications, if you look them up, have so many side effects that are greater than 30% incidence individually. And now you have a medicine with both of them combined. It works by suppressing the reward center in the brain for eating, kind of an interesting mechanism of action. It has GI side effects like nausea, constipation. Both of the medications have headache as a side effect and dizziness. And then the bupropion can actually cause seizures as a side effect, lowers the seizure threshold. So yeah, all of those have interesting side effects that we need to be aware of. Now, a lot of those symptoms are nonspecific, but knowing that they're related, if a person comes in and say, hey, I just started this new medication for weight loss, I'm going to have a lot of headaches, you would be able to make that association. And I think it's helpful to know. Erin, one of the things that Tracy and I did for many months and haven't in a while is what was the one thing that you learned that you didn't know from your review, or maybe something that was reinforced when you read it? Like, oh, I kind of knew that. You had mentioned one thing already. What was it? Oh my gosh.
Oh, the
The,
appendicitis thing?
oh, the appendicitis. Yeah. Yeah. Oh my
Yeah,
gosh. You already
yeah.
answered the question.
I was way ahead of you. No.
Is there anything else?
I think my takeaway from this is some of the things we've already talked about, that these medicines are just so common.
Yeah.
You talk about tracing the number of people you saw in the clinic today. There was a KFF poll done in 2025 that said that 1 in 8 people in the US are on these medicines currently. Not
Oh,
1 in 8 have tried them, but 1 in 8 are on them. Take just a regular clinic day, you're talking 6 or 7 people a day, a shift, that are on these medicines. More and more people are taking them too because there's new indications coming out for these medicines. So that's going to increase that number. There's oral formulations coming out, which is also going to increase that number. Patients don't want to inject things, they can take a tablet instead. So I think just the number of people on these medications, and then you think of this broad range of complications, side effects, potentially rare things happening. I think my biggest takeaway is just keeping all of that in the differential, just
Mhm.
remembering that these medicines are out there. You mentioned don't assume that the side effect or this nausea and vomiting is from the GLP-1. There's all these other things that could be happening, but also don't assume that the nausea and vomiting is a viral infection. It could be a GLP-1. Just with the huge number of people on these medications, I think is my big takeaway.
First of all, I think I'm going to start adding that to my questions. Whenever I have a female with nausea and vomiting, I always ask about pregnancy. So I think I'm going to add GLP-1 to that too. Are
That's
you
the
on a
extras.
GLP-1?
Yeah.
Are you on something for weight loss medications? I wouldn't say I had no idea about the hyperkalemia, but when they pointed that out, I was like, oh, yeah, that kind of makes sense. And I think maybe have a lower threshold for looking at electrolytes when someone presents with nausea and vomiting related to the medications, because you don't want to miss hyperkalemia. I had someone I was working with the other day, long story, but patient came in with lab results and he had a potassium of 6.2 from a week earlier. And the person that I was working with was like, oh, I'm just going to refer him back to his primary care doctor. And I said, well, did you do an EKG? And the response was, well, no, because that was a week ago. And I'm like, well, how do you know it's not 7 today? And he goes, well, he was asymptomatic. And I'm like, well, you don't know that a person's symptomatic from hyperkalemia until cardiac
When they're
arrest.
symptomatic, it's bad.
I know, right?
Yeah, until they have an arrhythmia, you don't really know.
That's the time to catch
So,
them.
exactly. So you really need to do that EKG. So maybe have a low threshold of checking electrolytes and maybe even an EKG on someone that you suspect might be having an issue related to the GLP-1s. So that was my takeaway on that. But I think just added awareness of these drugs are here, they work. People are losing weight left and right on them. So people are going to go through any extreme to try and get a handle on that, because people fight obesity their whole life. When there's something that seems like it's a panacea and it's going to help, they're going to do whatever they need to do to get them. And not just the people that are using it for weight loss too. These same side effects happen to people that are taking it for diabetes and trying to decide, like, is this DKA or is this the side
Mhm.
effects from the medication? So definitely something to have a low threshold to try and sort out. If you're concerned and you don't think that you can manage this in urgent care, please err on the side of caution and send the patient to the emergency department. Joe,
Yeah.
how about you? You have anything surprising or
You guys,
anything
you
else
guys
you want
took
to
the
add?
good ones, but right at the end, euglycemic ketoacidosis, even in a non-diabetic patient, I think that's just crazy. It's such a tough diagnosis anyway. If the patient has diabetes and you can run a bunch of labs on them, you can figure it out and look at their gap. And if the first class of medicines that seemed like it was correlated with that were the SGLT2 meds, so somebody would come in and one of the flozins or medicines that ended in that name, and then they'd just look sick, but they wouldn't be. Maybe their sugar would be 200, not that 250 that you're thinking of DKA, but they'd have a big gap, which could be from the vomiting. It'd be kind of hard to figure out. But gosh, if a non-diabetic patient can go into euglycemic DKA, that'd be tough. They're probably going to look sick. If you see them right at the beginning, you might miss it. But once they really start to look sick, that's when you would send them to the ED and somebody else would hopefully figure it out. But that was surprising to me.
Interesting. Well, I think that wraps it up. I would like to thank Erin for joining us today. That was fantastic.
Thanks for having me. This was
Yeah,
fun. My first
Well,
podcast.
oh, yes. We'll ask you again sometime if we have something that's up your alley.
great. Thank you guys very much. It was good to talk
All
to
right.
you.
All right. Thanks so much. And keep a high index of suspicion about GLP-1s.
Very
Definitely.
good.
Bye-bye, everybody. I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.